Okay, so today we're privileged to be joined by the ladies of the SCI social work team. We have Maria, Joy, and Krista online, and we're going to start the virtual Zoom meeting and receive information on COVID-19 as it relates to the social workers and the programs that they manage. Ladies, however you want to start, please.
Okay, well, we've had you may or may not be aware of some of the procedural changes we've had to do with appointments and so forth. Unfortunately, we've had to cancel a lot of the annual exams that we had scheduled because we're trying to reduce the amount of patients that come in and out. Just for exposure purposes, but we're really coming together on the use of the VVC or to do video visits. Oh, hello. And we're actually getting better and better at coordinating that. It's kind of a new process because nationally we were supposed to be only doing in-person exams for the annuals, but we're getting some really good feedback through these VVC visits that the veterans are liking that, especially if they live really far from here and normally would have to drive in for their annual. Like this morning, we did one for a gentleman that lived up north by Appleton, and he said, I have to leave like 5:30 in the morning to get there for my annual, and this is awesome. I don't think it can necessarily replace the ability to do an annual exam fully because obviously OT and PT can't do like manual muscle testing and things that they like. We can't do labs. We can't do an in-person, like a hands-on exam. But I'm wondering how you guys feel, knowing that you guys get annuals too, how you would feel about using VVC as a mechanism for an annual, maybe on like a intermittent basis or like an every other year basis or something like that. We're trying to kind of get as much feedback as we can from how people feel about
that. I think it's good to use in a situation like we have now, and maybe periodically, but there are things like ultrasound, that we have done during our annual exam that cannot be facilitated this way. Right. Unless you have some really cool high-tech equipment you're going to issue us to, rub the jelly on our bellies and do our own scans. But there are other things too, the lab work that's important, or blood draws. For me, the cancer aspect of my care and having all of the MRI scans available for my annual exam. So I don't think that this virtual annual exam can be a replacement. It's not a good replacement, but it's a good substitute instead of nothing at all, my opinion. Mr. Matthews, what do you think?
Well, I would take a little bit of a different look at it and say it should be a doctor's call. If they want the patient to come in, then everything should be done to accommodate that. If they can do it virtually for a year and maybe alternate years, I think that would be a good idea, just to save on mileage and cut down on some of the expense. If they have to come in sometime, they can do their lab work and that sort of thing. But yeah, I guess it would be up to the doc whether or not they have to come in. I don't mind coming in and doing it, but I'm half an hour, I'm an hour away, so it works good. But for the guys that are 4 or 5 hours away, would avoid having to go inpatient and that sort of thing with a lot of people. That'd be a big cost saving.
Yeah, we were toying with the idea too of, in the future, and I know that nationally this will probably be discussed in greater length, but we were toying with the idea of maybe we could do like a 2-part annual where we had you come in to see like the NP, the physician, occupational and physical therapy, had your labs drawn, ultrasound, But then the other providers like psychology, social work, dietitian would maybe not necessarily need to be an in-person visit tagged on to that long morning. Like maybe there could be a VVC component to the annual and then an in-person component to break it up a little bit. But I don't know if you guys would find that to be more disruptive. Then that would be basically like 2 different time commitments. You'd have one for the VVC portion and one for the in-person. But it was being discussed, you know, because we're going to have to somehow catch up with the annuals that we missed. And we thought maybe that might be a way to do it. Do you have any comments on that?
Well, that perfect scenario being the traditional annual exam that we're accustomed to, not just for us, but for you as providers, that round robin, I don't know what the right term is, when you all come together at the end of the day and discuss every patient. I think that's very beneficial to you guys, because Maria may have picked up on something that OT didn't. And that crosstalk about that whole experience, I think, gives you a better picture of the veteran's health.
It does. Yeah, that's a good point too. And we'd probably still have to, we'd have some of that if we did that. But yeah, there's no decisions right now. We're in the middle of just trying to get through right now. But so far the VVC, the feedback we've gotten on the use of the VVC has been really positive. So I think that's what's prompted the discussion, is to see if maybe that makes sense to do more of that.
Oh, no, it's okay.
What platform is that on? Is that through video telehealth?
Yeah, through the telehealth. Yeah, the VO.
So they have to have a PC to do that, correct?
No, they can do that through, like, if they have an iPhone or a tablet, we
we're
can
working
establish a
on
link
it.
to do their visits for those devices too.
Okay.
Looks like Maria's getting a consult.
Yeah.
Is,
Oh, okay. Just
Always
a
busy
little
we
bit
are as
longer.
social workers.
Yeah. Okay, thanks.
to kind of change the subject here. Did anybody else want to comment on that? We had a couple other guys come on board.
You didn't hear the question.
Oh, this had to do with the virtual annuals that they're doing.
I was gathered that's what it was.
Yeah.
I've already been talking with most of the doctors at like the psychology portion, like she was just mentioning. I've kind of had that done since I've missed my annual. The only thing I haven't done is the physical part, like the blood draws, the urine, and speaking with the doctors one-on-one. So far it's working fine. That aspect of it, is it perfect? Maybe not. It's probably, I think it was always good to be able to go to the hospital and get it all done at once. But if we're home and we're sequestered, I don't see a problem why they can't be called and do half of the program like we're doing right now. So far, at least for now, I think it's working fine this way. It'll be nice to get things back to normal, of course. That's all I have to say about it.
Sure. Yeah, so you like getting it done all at one time, it sounds like.
It is nice to have it done at once, but I'm adapting. I'm learning to use this technology, and it seems to be working. I mean, I think it's working fine so far.
Okay.
I haven't had a need to go into the hospital, so that's I'm lucky that way.
That's a good deal. Yeah.
Yeah.
Yeah, so one of the other, was there any other comments about that or feedback about the annual exam process from anybody, or Peter? I don't know if you had anything you wanted to say about it, or. Okay.
No, I'm not really, but the actual physical, we catch a lot. I mean, there's a lot of stuff that happens there that you really can't miss out on. Like last time they found the cancer that I had, it's important.
Yes, it is.
Yeah. So Well, more discussion to come, but I know that was one thing we talked about is could there be components of the annual that we could do via telephone or VVC or video just to shorten the amount of time you were here in the morning. So we've had some people say that would be great, like a whole morning being there. I'm so tired. By the time I'm done, that's like I'm ready to cash. And then other people have, said no, they like it all in one. So there's lots of feedback we're getting, and we're trying to use that to figure out if there could be any form of process change with annuals, or if we should keep it just the way it's been.
Well, as long as I don't have to be faced with my weight gain.
Just
no more scales.
Right? Okay.
So I think another topic that's near and dear to a lot of our members right now is the effect of loss of income or potential loss of income during this situation, and how that may affect their home situation. Are there any programs that have been started or initiated due to the current situation?
I know there's been some, we just got a notice today about some of the programs being expanded. I don't know that any of you participate in those programs, but some programs like the food share, it used to be called food stamps. And some of those programs that are more like county-based versus VA-based are expanding eligibility right now. So that's helpful for people that rely on that are really low income. I know, I guess I would encourage, and I've been encouraging our vets, if they have financial concerns, to call us, because then we can always try to tap into like volunteer resources, community resources. There's a lot just kind of funneling out there, and there's not really a great way for it to be organized right now. But I would try, if someone approached me and said, hey, I'm really struggling, I would try to reach out to like our VSO, our county veteran service office, and whatever community resources we can pull in. It's really individualized based on people's situations. So
Didn't we just hear
Oh, go ahead.
in one of these conversations where there's like you dial 211 for food?
mm-hmm. Yeah,
Is that correct?
That's the 211 is a helpline that they can try to connect you with resources based on your needs. And that's a great resource.
That's not just food, that's almost anything, is that correct?
That's anything. It's kind of like a general resource referral line. And they try to connect you with housing resources, financial resources, whatever kind of resources you need. They don't necessarily always know VA specific things as well as VA staff do. That's the only downside of that, but they do know some, so that's helpful.
The subsistence aid grant was also liberalized and clarified. It's just easier now. There's less of a process to get that. So they took away a few roadblocks for that grant. And that's also through the County Veteran Service Office. And that's basically just money, like in an emergency. So like to pay your rent and that type of thing.
Okay.
Yeah, I think they're trying really hard to loosen or expand eligibility to the greatest extent they can. And yeah, hopefully that will be helpful.
Super. I wrote that down, 211. I'll get some information and get that posted out there on our social media page. Expansion of the family caregiver program. Have you ladies been read into the legislative guidance that's coming down on expanding that program to pre-9/11 service-connected injured vets?
Yeah, I know that's been expanded, and we kind of defer like specific questions about that to our facility caregiver support coordinators, which they've actually expanded that program overall. So we have Kevin Thompson, who used to be spinal cord, as many of you might remember, our spinal cord social worker. And then we have Ida, who's based up in the Green Bay area. And then we just hired a third caregiver support program coordinator. So we kind of defer to them on specific eligibility, referrals and things. They are expanding it, but last we checked with them, they hadn't really gotten it off the ground as far as how they were going to manage that expanded program quite yet. So
Okay.
do you guys know we have caregiver support program coordinators here that run?
What part are they expanding?
There was the first part was just like the post 9/11. It was just for like people that had just been coming out of the 9/11 with combat injuries and things. And now they're expanding it to more general. And there's a name for it. I'm trying to remember. Do you remember, Maria, what the newer name is?
I'd have to look it up.
They're trying to kind of separate those two out, and there's a name for the new one, but the new one's supposed to expand it to more general services. So like people that aren't necessarily just post 9/11, but other eras, anybody who needs caregiver support, and trying to expand the eligibility for that. And that's just pretty new. So we haven't really gotten off the ground real great with applications and things, but our caregiver support program coordinators are trying to keep us updated on when they're really rolling with that. And if we have potential referrals, we're supposed to be referring to them. So they're available for questions too. They might be a good Zoom meeting for you to just talk about those programs like in greater detail.
That's a good recommendation.
Yeah.
I actually just referred someone yesterday, and it's the wife of a veteran who's here for rehab, who's very stressed because she can't come see him. So I asked for a little extra support for her through that program.
Super. And I know I saw some Facebook, or it was actually the VA did a press release where they showed Aaron in a patient's room using, I think it was FaceTime or Skype.
Yeah, they've been doing that with all the inpatient rehab and anyone who wants to visit that way with their family. It's really been great. That was a nice article.
Yes, it was. So have you run across anyone? So you have the technology in-house at the hospital. Have you ran into a scenario where the family member doesn't have the technology to connect?
Not that I know of.
So far not. I mean, because they can use a lot of different forms of technology on that end. You know, they've been able to connect with iPhones or laptops or tablets. We've just done some phone visits, honestly, for people that are more comfortable with the phone. This is honestly one of the most challenging times for our guys here that are in the hospital, because as you guys all know, family support is so important in the recovery process, especially for newly injured veterans. It's been really, really challenging. So we're trying to facilitate whatever we can with that technology to keep them connected. We actually had one family member that came and they went to the PT. You know how we have our big PT area out there with the big windows? They just went outside and the vet was inside, and there's glass in between them, but they were able to just see each other and talk over the phone, and it was like you were kind of together. Not the same as being right together, but at least it's an option. We're trying to make exceptions for certain situations to bring people into the medical center. So one exception that we've been trying to really accommodate is if the veterans here, they're getting rehab, they need to come in the caregiver needs to come in for training, like on how to do bowel care or how to use the lift or do any of that. We are going to be allowing that and just being really careful about how that individual comes in and how they're protected when they're inside the building. Because that's it, you know, you can't do training over the video chat when it's a hands-on kind of thing. So
and for palliative care, we've been able to allow families to come in. We just had a veteran pass yesterday, but his family was able to come in and meet with the doctor and meet with their loved one, and I got involved in the family meetings, so it was nice because Fisher House accommodated them too, and
Good.
able to say goodbye.
Yeah, so Fisher House is working with us and allowing families just to stay. They're not, keeping them out of there if we need to bring them here for specific purposes. But just the routine visits are still being restricted just for safety.
Is Fisher House full or?
No, this family was the only family there.
Yeah, with the reduced hospital visits, they're really, really under capacity, which is, pretty much assured that we can get it done when we need it.
Everybody's under capacity right now, it seems. And not much in sight.
Mm-hmm.
Has there been any new patients brought in for the SCI Center for rehabilitation or anything?
Yeah, we have one coming Monday.
Monday?
From Madison, and then we've gotten other referrals, but some of them don't need rehab like right away. They've already had rehab and they're just new to us. So with those, we're trying to set up initial annual exams.
This is like
by
a new
Skype.
injury?
They might not be newly injured, or if they're newly injured and they need rehab, we're bringing them in. Acute medical is the other reason for admission. But the ones who are just trying to establish initial annual exams with us, just to get established with us, we're doing those by Skype, which is not ideal.
No.
But it's a way to at least, like one guy just left Freighter. He got his rehab there, but he really needs some equipment, but he doesn't have insurance to cover equipment. So we're going to quickly get him through the system so we can get him what he needs.
So Dr. Lee is really reviewing any referral that we get where the person would like to be coming in here. He's reviewing them case by case. And he's trying to restrict the actual admissions that come into the building to urgent medical or new injuries or urgent medical. But he's looking at every case on what the situation is, because every case is a little different. And we're trying to address everybody's needs in the best we can.
When they come in, is there a protocol for cleaning their chairs?
Good question.
Yeah, I know they are cleaning. I don't know what the protocol is, but I know they are wiping the chairs down. I'm not sure who's doing that or how they're doing it. I'm assuming with probably Cappy wipes or.
Well, I'm wondering if the vets should be doing that if they go out and they come back home. Should there be a protocol for cleaning your chair if you've been out of your van?
Yeah, that's a really good question. And that might be just something we're not aware of, and maybe nursing has a protocol that we could ask them about.
I think I've seen something on that. PVA National may have something published, Ken.
I remember something being out there and I can't remember where it is.
Right.
I was looking for it the other day, just so we could get it up on the website.
Yeah.
So,
Go ahead.
how about finding people to take care of in-home visits? Are you having any difficulty?
Yes, very. Yeah. Actually, one thing that Krista and I have been having to do quite a bit of is getting catheter changes done by home care, because now the urology clinic doesn't want them coming here, and our own clinic is trying to not have people come in. So we've been getting these requests to set up a brand new home care visit just for catheter changes. I've been doing quite a few of those, and home care is always a challenge. There's a crisis going on out there. It's hard to get on a good day, and now you've got people that are afraid to go into homes of someone they don't know, and I think they're struggling with their own issues too, like childcare and sickness that they're dealing with. So the resource is a tough one to get. We spend a lot of time just doing that.
I was trying to make some referrals too yesterday, and there was a number of agencies that aren't even taking new referrals until May. So they said they would keep the referral on a list and get back to me, but it wasn't something that the family was willing to wait for. So,
and it's nursing home placements too. I mean, there's nursing homes that people need to get into, but they won't get in without an H&P, but we can't do an H&P if we can't get you in and get you seen. Same with chest x-rays, not being able to be tested for the virus, they won't admit you. So that's been a challenge. I don't know if, Joy, have you had to deal with any of that?
Not yet, thankfully. But yeah, I mean, I know just with us following the vets that are placed in the nursing homes, those assessments were coming up due, and we did our best to do those over the phone because we can't visit. So
I think it's very interesting. I think, Joy, this predates you and maybe you too, Krista, but a long time ago, the SCI Center was on the 10th floor of the hospital. And Dr. Lee was able to use the momentum of 9/11 to convince, the legislative branches that it was imperative not to have paralyzed veterans on the 10th floor of a hospital that an airplane could fly into. I think this current situation has shown similar importance on the need for a spinal cord injury long-term health care facility right there on the grounds.
Amen to that.
Thank you. This is, I can't tell you how passionate we are about this topic.
Oh yeah.
You just like hit
Don't
it.
get it.
Yeah, I mean, I think that nationally, the needs of our spinal cord injured veterans sometimes are so complex and so unique. And we work really hard with the nursing facilities on education and training, but I think that having a spinal cord injury specific long-term care somewhere within our system is absolutely necessary. I've talked to Dr. Lee about it multiple times. I'm hoping there will be some problem solving along those lines. Because we literally have a couple guys that we're just not, if we place them out of here, they end up back here right away with repeated wounds, respiratory issues. It's really challenging.
Well,
PD.
and certain
The
guys
nursing
can't.
homes are understaffed so severely as it is, then to try and expect their staff to accommodate these higher level of care patients, they just struggle with that.
Unless you can get an outside agency to come in and care for the person.
And they won't usually allow that because then that becomes a liability issue for the nursing facility because they're in their facility, but there's someone else delivering some component of care. They will do that if they're on hospice or things like that. But if it's something like because I proposed that once, I'm like, could we have the nursing facility do everything for the veteran other than maybe their bowel program, and then have someone come in and do the bowel program that's really working well with that person and knows kind of how that goes for that veteran, and they won't allow that usually because then it's like delivering medical care under their roof kind of
It
thing.
would be okay in a group home though, because
Right.
we do that, but
Yes.
that's a whole different thing.
Yeah, but that my experience is, if the veteran needs something as complex as turning every 2 hours, a bowel program that might take a long time, a number of other medical interventions, and then they're on, like, say, state assistance or medical assistance or Title 19, the facility actually says by the time we do all of that care, we actually lose money on the veteran. And, I hate when they refer to it as like a financial kind of thing, but, they're a business too, I guess. But then we're kind of in the position of trying to be really protective of the needs of that individual and making sure they're getting what they need. And it's so challenging.
My favorite places are still always the veterans' homes, because we get people back who tell us they're happy there and they feel like the care is good. I go by that more than anything else. I have a level of confidence with those places, and a selected few that we've worked with. But in general, I kind of cringe when I have to place someone if I can't use a veteran's home, because it just worries me. And I know Krista shares this feeling with me. We've seen bad things that happen because they come back to us. And
Right.
it's hard to reassure a family, you know, this will be okay when you know what you know. So.
Do you see a do you see a role for the PVA in advocating for that in some way?
Yes, I think Krista could speak to this more because she's done more of the research, but we have 38 beds here and we're not using all of them. And why couldn't we convert some of those beds to long-term care beds for spinal cord injured veterans?
Well, because the whole facility has to be, it's got to do with the way the facility is laid out and the criteria for the facility. Dr. Lee has been approached on this for a number of years, and the message is basically the same. They have to really change the way the protocol goes in order to make it a long-term care. It's just a whole different type of building.
Could we set aside 10 beds? Or
Well, I
could
don't
we?
know. They would have to close off one part of the facility and have it as independent entrances and different fire protection protocols, and I guess it's quite a change.
It is, and it also opens up a whole set of another regulatory system that would regulate long-term care. And there's a lot, I think that Dr. Lee is just not comfortable undertaking. And I think he's worried too, like if he surrenders some of our beds and then we end up needing a lot more of our acute care beds and we don't have them. So I understand those points. I just wish there was some other resource. We had built those greenhouses. I don't know if you guys have seen those greenhouses up the hill, and our original thought was, could we make one of those accessible, put ceiling lifts into it, staff it, make that a long-term care setting. They haven't really decided to go forward with that as a medical center here, but conceptually, I think that could be possible.
So interesting enough, it only costs $6 million to build a 12-bed facility. And that's not a lot of money. The longer obstacle is the staffing of the facility, because even if PVA was to say, here's this brand new building, boom, we put it right here in Milwaukee, here are the keys, it has to be staffed. And as you know, and as you've articulated, it needs to be staffed separately than the SCI center and not out of hide from the SCI center. It should be staffed as two completely different entities. And then the long-term bill payer for that is the VA, even if they were to be given a building with the keys ready to go. And that's where the buy-in of the VA leadership, Dr. Zumcheck, Dr. Lee, they have to buy into that concept and be willing to pay for that overhead.
Mm-hmm.
You have a simple solution though.
Well, think about it like the Fisher House.
No, I've got another thing to talk about though, in relation to this, because in the 1176, right, Krista, it says that we're supposed to be able to use the nursing home beds, at least 10 of them, and we don't use any. I think we have 1, maybe 2, and this has been pushed and it's in there, and why are we not using those beds? Okay, that's
so
it.
This is, so that everyone
Set my
understands, so that everyone understands, you're referring to
CLC.
the nursing home, long-term care facility within the VA structure.
Right, it's already
that
there.
appears to be open to everybody unless you're spinal cord injured. Yes?
Well, no, in the 1176, if you review it, it specifically says the Milwaukee VA Medical Center has 10 beds allocated for long-term care for spinal cord injury.
Really?
Yes, it's in.
Okay.
It's an addendum inside the 1176. You know, when I've talked with our administration about that, they've said, you know, we really don't have the ability to comply with that directive right now because we don't have space available. They don't have space available for the veterans coming from the medical center that need long-term care. I mean, it expands beyond just spinal cord, but you know, I wish that we could accommodate that because that might solve the problem for at least a handful of our complex vets that need that long-term care. The alternative right now is there's a couple people we're just kind of hospitalizing and keeping here, and
Yes, you are.
very, very expensive care, and it's also not fair to veterans that we say, no, we can't provide long-term care to you. It's so frustrating as social workers trying to realize there's a resource need and not be able to actually fill it. But we're constantly trying to propose ideas and solutions and, you know, be advocates.
That's good. We've got some crazy ideas, and we would love to get the data that you ladies have to support, you know, any initiative that comes from PVA. That way we can quantify it. You know, the dollars, the amount that it costs to keep an SCI veteran on the SCI floor, you know, those dollars per day and what that would equate to if they were in a long-term care facility. So you got to break it down to dollars and cents sometimes to justify it, but it doesn't make sense in any of our heads that it only costs $6 million to build the facility. That's not a lot of money, and that's for a 12-bed SCI long-term care facility. So the bigger cost has got to be the staffing aspect.
Is it true that Minneapolis is starting that they have one they're going to be building?
I know there's one on the West Coast. I'm not sure about Minneapolis.
Yeah, Minneapolis has told us that they're working on opening a long-term care there. And of course, we always have, you know, within our vision, we have the Hines spinal cord injury long-term care unit, and we're supposed to be able to draw on them to make referrals. But, you know, how many of our gentlemen who have families that live in Milwaukee want to go down and live at Hines and then have it be really far for their families to visit? It's not ideal either. And then on top of that, they're really full there, so that, you know, they never have an opening at the Hines long-term care.
Again, even if you were to magically inherit a 12-bed facility tomorrow, how soon would it be at capacity?
Immediately.
Oh, we could fill it.
Exactly.
Yeah.
So
No problem.
Because we do have, you know, several veterans living at long-term care facilities now that aren't happy there. You know, they're marginally happy, and we're trying to work on optimizing their care there. But if they were given an option to move into something that was a little bit more tailored towards spinal cord injury, they would, I'm sure. I can't say everybody would want to move out of their facility, but a large portion probably would.
The other part of that is they could begin to take part, at least those that are capable could take part in some of the rec therapy stuff that goes on.
That would be really nice, yeah.
A lot of them can't do that right now just by the nature where they're located. And right now, a lot of long-term care facilities aren't allowing people to go in and out. You know, they just lock them down.
Right.
Of course, they do here too. So.
And no visitors.
It's the same. Yeah, no visitors. That's very challenging. But, you know, we're like, we have one gentleman who's going to a nursing facility next week, and they're being very accommodating with, like, allowing Michelle, like our PT, to go over there and do some targeted training on making sure his wheelchair's like understood well, and so they're making some exceptions to that, but generally they have the same restrictions with visitations and things. So that's hard for placements too. If we have new people going to new veterans that are entering nursing facilities, having that family support, just the same as if they were newly injured and coming here, they're moving to a new living arrangement. That's a stressful time.
Right.
And then to not have their families be able to come in and out and sort of be there for them is
Right.
very challenging. So it kind of gives us another barrier to wanting to like facilitate that placement, because we know it's going to be really stressful at the beginning. But
And Krista and I both had people ask if they could just stay here and wait till this is all over and then go to the nursing home. And we'd like to do that if we could, but we're not able to.
Sure.
And then, as Krista said, we have some people who have been here for, I don't even want to say how long.
3 years.
3 years.
And now there is something that we are trying to explore about being able to charge them as under extended care, just like as if they were going to an adult daycare center and they would be charged per day. That might make a difference, but we might be able to use some PVA support on that.
Yeah, that would be interesting, because the federal government has a really hard time charging the federal government.
yes. Yes, but that's the one, if you look at, catastrophic disability really does exempt veterans from pretty much all co-payments. Other than in the regulations, it says institutional long-term care. So that would be like a nursing home, or if they're here in the medical center, in the community living center, or in any
Adult daycare.
Yeah, institutional long-term care. That is subject still to a copay. Even if you're catastrophically disabled, there's a financial assessment that is done to determine if you have a copayment for that care. That's the only one little tiny exception in that catastrophic disability category. And we just kind of, if they're here on spinal cord in the hospital, then they're technically not in long-term care, they're in the hospital. So we can't we can't subject them to that copay exemption.
So just for clarification, are you talking about the veterans who have other than Social Security insurance? The veterans that have private insurance? Because again, the VA cannot charge the government because they are a government entity. So the VA will never get any Social Security money.
Not insurance. It's actually just, it's a copayment.
Yes, they could technically bill the veteran as a bill, like generate a bill to them, but only, catastrophic disability pretty much exempts you from getting any bills. So you don't get billed for medications, visits, equipment, nothing. But in the regulations, institutional long-term care is the one exception to that. So like if you're living in a nursing home and you're catastrophically disabled, that doesn't necessarily prohibit us from being able to generate a bill for that.
But if they pass the VA means test to receive free health care,
right. Well, then they
how are you going to bill them?
The billing, the way that works is then there's something called a 1010 EC form. It's a long-term care. Basically, they call it an exemption test, where you have to report all of your income, all of your assets, all of your expenses. It goes into a formula, and then it spits out an amount. And it might say, oh, you have zero copayment for long-term care. Or it might say you have $22 a day for long-term care. The highest it could be is $97.
Oh, shoot.
Okay.
I'm sorry. Yeah, 27 it should read. Do you want me to change it? Oh, you got it.
Well, I have a,
Do you want to mute your microphone?
Sorry.
Yeah.
I'm so mixed up. There you go. Because by the time I got it, it was
Go, Pete.
is that covered by private insurance? Private insurance, that copay?
If you had catastrophic is what they were saying.
Right. If I'm catastrophically disabled, but I also have insurance through my wife. So would that take care of that, or would I still?
Yeah, probably not, because they could bill your insurance. Your insurance is only going to pay a certain amount towards long-term care. So I don't know. Yeah, that would be, we'd have to check. If you were in that situation, we would check with our billing experts on what that would mean. But
No, okay.
yeah, and it's not. I'm not saying that because I feel like we want to bill veterans,
That's all.
veterans for things. But if we have certain veterans that are reluctant to look at options outside the VA, in favor of just kind of remaining with us here, that might create an incentive to want to work with us on options.
So that's all on an individual basis once you get in the hospital and you figure you're going to stay there for a while.
It's basically once the doctor says you're medically stable, you're ready to move to a lower level of care, and they refuse to go. And we've offered options, like they're out there, but we can't move them because they say they won't go. And then we don't have any leverage. We have no way to encourage this to happen.
Yeah, that we don't understand, because that's completely illogical that you guys really can't. If there's an acceptable facility, to us it's illogical that
Right.
you guys can't move them out.
Nobody will do it. We don't have leverage in the VA.
I know. All of you have shared the war story, so I believe you don't. But there's got to be a way to fix that within the VA somehow. That if you don't meet this criteria and there is a comparable option, you got to go.
Yes.
What do you think, Mr. Matthews? I see
Totally.
the wheels spinning.
Well, again, this is an area we've been struggling with now for a number of years. And, it's imperative that we come up with some kind of an option for guys outside of nursing homes.
Yep.
We need foster care.
Yeah, so a lot of VAs have what they call the medical foster home program. Maria and I have a dear social work colleague that is running one of the most successful medical foster home programs in the country at the Minneapolis VA. So, in those cases, we can refer to that program, and they facilitate getting that veteran placed in someone's home that they're equipped then and licensed to provide the right care for them in a home setting. Without that program, though, we're kind of like taking stabs in the dark. Like, there's so many different people out there that want to run a foster home without somebody kind of overseeing it and regulating it and really seeing that it's safe and that it's an option. It's really hard to facilitate sometimes. So I've proposed that our medical center take that on as a program, and there has not been an interest in an administrative level in that. But there's been discussion about it, so.
VAs throughout the country are running medical foster home programs, but Wisconsin is not one of those.
So then that data that you have from your peer in Minneapolis would be important information too, should this long-term care facility come to fruition, and all of a sudden you get this magical brand new building that's built for 12 beds for SCI. When you look at the staffing cost, you could say that, well, if you had this other VA approved program for an SCI long-term care foster home, VA would be paying X amount of dollars per month to keep that veteran in that foster home, yes?
The VA is not really paying it. It's privately paid thing.
Yeah, so they just facilitate the placement, and they work on trying to make sure the veteran gets aid and attendance if they entitled to that, and maximize all the VA resources that they can get eventually. And then they oversee the care of that veteran and support it with like home health staff and things.
So the VA is still on the hook for some monies, whether it be aid and attendance or monies like that, where if they were in a VA long-term health care facility, they would waive that compensation, yes?
They would, they'd be It's the same financial obligation that they'd have for benefits that they normally would have, because that veteran's probably going to get aid and attendance, whether they're at home and a nursing, wherever they are, they're going to be entitled to that. That wouldn't change. The cost of, extending some regulatory, because there's a medical foster home program coordinator that you have to pay. There's home health, a lot of programs will use like their HVPC home care programs and things to go into that medical foster home and oversee the care to make sure that the training and that the care being provided is adequate. So the costs are more staffing, I think, than actual other costs.
Okay.
But yeah, so far our medical center has not felt the need for that resource, but that could be a good resource for us to draw from for coordinating, finding safe places for long-term care for our guides. We have a couple of veterans living in adult family homes right now. I know Joy sees one through home care.
Yeah.
How's that working out, Joy?
Well, it's going okay. We've had some issues with it just in regards to the home care going in and not really managing some of the symptoms appropriately. But it's tough to get workers that are fully educated in how to deal with some of these issues that our veterans have, because they don't really get paid all that great. So that's a whole nother issue.
So when you say that, Joy, is that something like, something like autonomic dysreflexia, training for awareness of that?
Yeah, I mean, and this is just a simple high blood pressure issue that was continuing, and the nurse just wasn't alerting anybody about it. And then it got to the point where he needed to be hospitalized. So, there's high turnover, and there's just not, I don't even know what the requirements are for some of these aides and workers that get hired by these home care agencies. I don't know how much training they get. It doesn't seem like they're
kind of
high standards.
I'm just trying to understand that I know that the VA through the home in the VA's home telehealth program in its infancy, we used to get home blood pressure machines, and we would report daily on our blood pressure if we were in that high blood pressure category. It sounds like that would be an easy fix.
Yeah, we did get him connected with that.
Okay.
So he is on that program as well.
Perfect.
I don't know.
Yeah, that's a challenge overall, though. If there's a lot of home health agencies that don't want to take on bowel care. We make a referral and they say, "Oh no, we don't do that." Then you make another referral. "Oh no, we don't do that." Or, "Oh, we have one person that does that, but her schedule's full." So we could be going through 20, 30 agency referrals sometimes to find one that will do bowel care.
Wow.
That's not unusual. That's a large part of what we do.
There's a resource need there, and I'm not sure what the answer to that is. I don't know how PVA could make an impact there, but resources in the community that we have to draw from seem very limited sometimes, depending on where you live and what's out there.
Quite often, home health care want that done by a nurse.
Yeah.
Right, and when we have to, we actually don't have a qualms of paying an RN to do bowel care. That's extremely expensive, but if that's the only option that we can offer that veteran, we will do that. That's a last resort, because technically, we could easily train a CNA or an LPN to do a bowel program, and most agencies agree with that. Some do not. They say that's an invasive, if you have to administer a suppository, that's an invasive procedure. Only an RN can do that.
Yeah.
But we're not going to say as a VA, I'm sorry, then no, we can't pay an RN to do that. We will do it when we need to.
We often have to cobble together a few agencies, not just one, to make it work for someone, especially in a rural area. I have one guy up north who's got 4 agencies.
Wow.
And private bowel and bladder reimbursement program.
We often advocate for pro pay for SCI nurses. It wouldn't be outside of our wheelhouse to advocate for pro pay for home health care providers that provide those services. There's probably, what I'm hearing is there's a need for that.
I wish we just had our own home care that would go out to do this type of care, like aides. You know, aides to go at maybe 10 or 12 that could rotate around, even if we couldn't cover every area, because of course with 400 some people you're not going to get all areas. But I think the Metro Milwaukee area, we could alleviate so much of the stress and just the work for trying to get staffing.
Joy's probably going to chime in. I think you're underestimating the census just in the Metro Milwaukee area of how many people that would take.
I don't know. I think that's a good idea. I would welcome that.
Or, you know, as maybe an emergency backup. So for instance, I have, you know, a veteran who has a really capable caregiver for bowel care, but there's not, with that agency, a lot of backup that they could just jump in and immediately know how to do that bowel program and do it effectively. And so then if that caregiver becomes ill, this is all part of emergency planning stuff, but if that caregiver becomes ill or does not show up or quits, which is actually what happened this week to someone, the veteran's calling me going, who's going to do my bowel program? Like, what do I do? If we had sort of a repertoire of people, we could say, okay, until we figure this out, we'll send someone out to help you. But we don't really have that.
But that's huge for us. I mean, from the veteran's perspective, continuity of care is huge. We don't want to meet a new person every week to do bowel management.
Right.
But if you knew that they were from the SCI center, they were trained aides. That
Every week, I need mine done every day.
Oh, but yeah. Now you know I'm full of it. But
it's a really desperate feeling as a social worker for a vet to call me and say, my caregiver didn't show up. I have no bowel care. I haven't had bowel care for 2 days. What do I do? And I call the agency and they say, we're looking for somebody, but you know what? We don't have anybody to send right now, but we're trying. Like, what resource do we put in place for them? That's the really challenging.
And especially now, because we can't even say come in for emergency respite. I can't even offer that.
So that's surprising for an SCI veteran who hasn't had bowel management in 2 days. For me, I would need to be admitted to an ER. I mean, that would seriously trigger autonomic dysreflexia. I am in a crisis situation.
Mm-hmm.
Absolutely.
Why is it not treated like that?
It is. That's the alternative we have to offer them. Like, if you can't get a caregiver and we can't find anybody through that agency and we make 20 calls and there's not another person we can send, then you're going to have to go to the emergency room. We've had a couple of vets do that.
Okay.
But if you lose a caregiver and it's urgent, we would just offer inpatient respite. Just come
That's
in.
Normally what we do is
But we can't now.
We pull them. We say, you know what, you need to come into SCI for a little bit, maybe a few days, a week, until we can figure out what to do. Right now, that resource is not really there.
So Maria just said that too. So that's something that's unique to COVID-19, to the situation that the hospital is currently under, that you can't offer that. So without putting any names to it, can you put numbers to that? Because we need to raise that red flag.
I can tell you that one I was telling you about, who has 4 agencies and a caregiver, that was one of them. I got that call and I couldn't bring him in. The caregiver was possibly positive, but the test was still pending. Meanwhile, he had no care and he's high quad. I couldn't get him into Iron Mountain either because they weren't taking people.
Okay.
The only thing I could ask him to do is if he really needed help to go to the emergency room. But that's not something they would admit you for either. Maybe they would. I don't think they would.
And then, yeah, depending on the emergency room they go to, the familiarity of the ER staff on what to do immediately for that veteran could vary.
Yeah.
If it's in a small hospital in northern Wisconsin and they go into the ER, what are they going to do there? Are they going to handle it appropriately? We hope so. We can call the ER and talk to them, but we're not delivering the care in that instance
Right.
either.
I've had a wife of a veteran tell me that she had to tell the ambulance driver and the ER doctor that her husband was in AD and explain what that was and tell them exactly what to do. And she said without her telling them, it wouldn't have happened. They wouldn't have known what to do. They were treating it like it was a stroke. No, how did she say it? Basically, he just needed his catheter to work, and it wasn't working. And she had to explain it. Now, our spoke sites, they know, they've got it up in the ERs on posters, and they know exactly what to do. But a local community hospital, it's anybody's guess if they're going to figure it out, which is why we talk so much about self-directing your care. Because, you know exactly what's going on. And you know what to tell them.
And Scott, I've been encouraging vets to carry that AD pocket card with them that you guys gave us a big supply of, because that's been really helpful to be able to pull that out and say, hey, look, I have this pocket card. It goes over AD symptoms and solutions for people who are less familiar. That's a great resource that you guys were able to get us more of those cards, because I do give those out a lot.
Well, ladies, we really appreciate your taking time. We're well over our 1 hour. So.
Oh, thank you for inviting us.
A lot of passionate topics.
Yes.
Well, and
I know you guys all understand them too, so.
We could probably go on for the rest of the afternoon if we really worked at it. So, but thank you very much. And Scott, thanks for keeping it going.
You betcha.
Thank you.
Thank you, Scott.
Be well.
Thank you, ladies.
Thank
All right.
you.
Have a good afternoon. Thank you.
You too. Bye.
We'll see you.
Bye-bye.